So let's now quickly move to our roundtable discussions. We're going to begin with our physician discussion. I'm Mike Gibson. I'm joined by Dominic Angelillo, who you just heard from. We're also joined by Dr. Asif Ali, whose disclosures are shown here. I wanted to go to you first, Dr. Ali. You're actually using Vazalore in your clinical practice. How's it going? Are patients tolerating it? Are they adherent? What are some of their comments?
Yeah, thanks for the invitation. And absolutely, we have been using Vazalore fairly early on, especially when we're looking at patients with ASCVD using the secondary preventative indications that have been outlined in this talk. And, the conversation is with the patients, why pick a formulation of aspirin that is not giving the best efficacy and the base safety profiles? So it's not a very difficult conversation when you have a patient that comes to you with a stroke or a heart attack and you're discerning what the best medication options for them. And it is a class 1 indication to talk about shared decision making. It's very important that we inform the patients of their options and what are their best options. As you know, we have a number of medications that we onboard patients on status post a STEMI or a non-STEMI or acute coronary syndrome and unstable angina. And so really looking at the patients and discussing in that shared decision-making model what their best options are in regards to their aspirin use. And so for me, looking at the data, I don't think it's a very difficult discussion with the patients to say that if in some cases, and I think we highlighted it here today, in about a third of patients, they may not be receiving any aspirin. And these are life-saving drugs, as you know, after a stent or a heart attack or a stroke or even in peripheral vascular disease. We want to make sure we're picking the best formulations and the best medications that have the best absorption and therefore efficacy as well as safety.
Yeah, good points. Dominic, I wanted to ask you, I led a trial, the Pioneer trial, the first trial looking at dropping aspirin in the setting of atrial fibrillation with a stent. And that reduced bleeding, looks like pretty similar outcomes. You and I have written a lot of papers on this, but that seems to be getting confused with the person who doesn't have a stent, the person who has had a stent and is on DAPT, and people have said, well, we can also shorten the aspirin duration in those patients. To be clear, there have been trials, but many of them are small, underpowered studies. Yes, they do show a reduction in bleeding, but they weren't really large enough to look at ischemic events. So what's your take on this trend towards shortening the duration of DAPT?
Great question, and you make a very valid point. So to answer the first part of your question, let's not forget that even in the trial that you led, Mike, aspirin is still given to all patients and is still maintained for a certain period of time. And again, these are patients who are also on an anticoagulant. Okay, so it's not like we're saying we're going to stop aspirin. They have the P2Y12 inhibitor. Then we have all the other hosts of studies, which, as you mentioned, they were not designed to reduce ischemic events. They were designed to reduce bleeding. But again, there was still aspirin on board for at least 1 to 3 months. Great studies. You and I have been part of them. But again, we still then do not know what to do long term after 1 year and whatnot. And so the default strategy still remains for patients to be on aspirin monotherapy. So again, there's a lot of confusion out there. There's a lot of excitement surrounding the P2Y12 inhibitor monotherapy, and you and I have both been involved with it. But again, from a practical perspective, this still presents a number of challenges, and as you mentioned, not designed for reduction in ischemic events.
Well, I often think about NNH, number needed to harm. How many people do I have to treat to cause a bleed? We think about NNT, number needed to treat to prevent an event. But sadly, clinicians are going based on the NNB, number needed to blame. They don't want to get blamed for a bleeding event. So there's a lot of, hesitancy out there, and there's a temptation to shorten the duration because they're treating the stent, not the patient, but there's a patient attached to the stent. And of course, that patient needs secondary event prevention. 54% of the events in the DAP study were outside of the stented segment. So we've really got to think closely about secondary prevention after you're out of that acute stent thrombosis period and what's going to be the best strategy. One person asked Dominic, what about giving aspirin every other day? I mean, if safety is an issue, why not give it every other day?
Well, I'm against that strategy based on the fact that because your platelets turn over, okay, and you have replenished platelets, remember, aspirin interacts with platelets only as long as aspirin is around. And if you have 10 to 12% of your platelet pool being regenerated, these are not going to be exposed to aspirin. And so what's going to happen? You're just going to have a bunch of thromboxane being generated, and that's going to stimulate your other platelets. So my answer to that, it's not a good strategy.
I agree. I wouldn't be doing that either. All right. Well, thank you for this physician discussion. Well, this has been a great discussion. I think the faculty has done a great job. It's very clear that we really need to educate people about the importance of secondary prevention with aspirin. It remains a foundational therapy. We've got to get beyond just treating stents to treating patients. There is a patient attached to the stent, and they may have an event in another artery. I think we've heard about some new strategies today. I'm going to run through a few of the P's here. That phospholipid coating. Your stomach's coated with phospholipids. That protects it. It just makes sense to coat drugs with phospholipids to protect the drug from the stomach and to protect the stomach from the drug. And this kind of drug is getting across the phospholipid layering, almost like a Trojan horse fashion, to deliver the aspirin more safely, but also with those three P's, promptly, potently, and predictably. We've got to move beyond in our practice looking just at the p-value. Was it significant? That's the only thing we seem to care about. That's not right. We've got to look at other p-values. The most important p, as you just said, Dr. Ali, is the patient. Does it make the patient feel better? Do they live longer? Does it improve their outcomes? The second P is these days is price. You can't get away from payers. Is it cost effective? Are we going to be able to afford it? The third P is the physicians. Physicians are risk adverse, and does this fit into their practice? Are they going to be willing to give a drug like some of these newer formulations or the older ones based upon the risk of benefit versus bleeding? And all of these decisions are individual decisions for each patient. We have to look at the risk of bleeding and the risk of ischemia. Well, I want to thank everyone for joining today. I don't know if we have the post-test. Meg, do we have the post-test? There we go. So the post-test, real quickly, is aspirin a class 1 recommendation? Let's see if you learned anything. Click on the answer there, yes or no. Is the extent and speed of absorption with enteric-coated aspirin, is it, compared with regular aspirin, is it speedier, yes or no? And does the phospholipid coating of aspirin reduce gastroduodenal erosions and ulcers, yes or no? And submit your answers. Let's see how you did. Well, thank you. It's been a great discussion. I thought it was a lot of educational content presented here. Thank you for joining us today. This webcast will be archived. You can get CME credit. That's for physicians, advanced practitioners, pharmacists. Everyone can get credit for attending today's webinar. Thanks for joining us. We look forward to seeing you again in the future.